In today's presentation, we'll be exploring a deeply complex and clinically significant psychiatric case involving multiple substance use disorder, specifically opioids, cocaine, and alcohol, compounded by psychiatric comorbidities including generalized anxiety disorder and stimulant-induced psychosis. This patient also presents with a notable somatic complaints, particularly gastrointestinal distress and opioid-induced bowel dysfunction, that are both medically and psychiatrically relevant. We'll break down each diagnosis using current diagnostic criteria and evidence-based practice, while citing recent peer-reviewed literature. Our patient is a 32-year-old Hispanic male presenting to a psychiatric mental health nurse practitioner, PMHNP, for urgent evaluation. He reports a daily intravenous heroin and fentanyl use, along with a regular crack cocaine smoking and powder cocaine snorting. Additionally, he binge drinks daily, smokes 1 or 2 packs of cigarettes per day. He has untreated hepatitis C, chronic constipation, and epigastric pain. Socially, he is unemployed, intermittently homeless, and has minimal family support. He has a background of childhood trauma and history of non-adherence to past psychiatric treatment plans. My diagnostic impressions and the clinical evidence for this case. The first one will be severe opioid use disorder, F11.20. This patient meets the DSM-5 criteria for severe opioid use disorder, including loss of control, tolerance, withdrawal, and continue using despite harm. As Voloff et al. 2019 explained, chronic opioid exposure fundamentally alters the mesolimbic dopamine system, reducing the brain ability to regulate and reward and motivation. These changes impair prefrontal cortical functions, making it more difficult to make rational decisions about drug use. Clinical evidence shows that medication-assisted treatment, or MET, with agents such as bupropion, naloxone, and methadone significantly improve treatment retention and reduces opioid-related mortality. Census 2023. The second one will be severe cocaine use disorder, F14.2. This patient daily crack and powder cocaine use places him at significant risk for both cardiovascular and psychiatric sequelae. Cocaine acts as a powerful dopamine reuptake inhibitor, and repeated exposure causes neural adaptations that reinforce compulsive drug-seeking behavior. According to Exer et al. 2020, chronic cocaine use is associated with a reduced gray matter volume in the prefrontal cortex, an area crucial for impulse control and executive functions. While no FDA-approved pharmacological exists for cocaine use disorder, clinical trials suggest that topiramate and modafinil may reduce cravings. Cognitive behavior therapy and contingency management may remain the gold standard behavior intervention for this patient. Third, alcohol use disorder, severe, F10.2. This patient also meets the criteria for severe alcohol use disorder due to his daily binge drinking and resulting functioning impairment. Chronic alcohol consumption dysregulates the brain inhibitory GABA system and excitatory glutamate system, producing both physical dependence and psychological cravings. Knob and Volkov 2020 note that long-term alcohol contributes to HPA axis dysregulation, compounding psychiatric symptoms like anxiety and depression. First-line pharmacological treatment includes naltrexone and acamprose, both supported by recent meta-analysis, John et al. Gabapentin and baclofen are also under study for their efficacy in managing withdrawal symptoms and reducing relapse risk for these type of patients. Generalized anxiety disorder, F41.1. The patient reports chronic anxiety, frequent panic attacks, and restlessness, worsening during withdrawal periods. While stimulants and opioids may temporarily mask or modulate anxiety, their long-term effects on HPA-axis worse baseline symptoms over time. According to Garland et al. 2018, individuals with a high anxiety are more prone to substance use as a form of emotional regulation. Yet this cycle reinforces neurochemical instability. SSRIs and SNRIs are considered first-line treatments, though this patient previously discontinued them due to side effects. Bandelo et al. Recommended alternatives like pregabalin or hydroxyzine when benzodiazepines are contraindicated. Psychotherapy, especially CBT, remains essential for this type of patient. Stimulant psychosis 15.93. His reported paranoia, agitation, and intermittent auditory hallucinations, suggesting stimulant-induced psychosis, a diagnostic support by daily high-dose cocaine. Data from Harber-Cooper et al. 2022 indicates that nearly 50% of chronic stimulants users will experience psychotic symptoms, especially in the presence of sleep deprivation or poly-use drugs. Multidisciplinary treatment recommendation. This patient prognosis hinges on a coordinated multidisciplinary care plan. Intermediate referrals to inpatient detoxification is indicated due to the high risk of overdose and complicated withdrawal symptoms. Medication-assisted treatment should be initiated for opioid use disorders first, and non-stimulant-based pharmacological treatment should be considered for anxiety and psychosis. Cognitive behavior therapy, motivation interviewship, and trauma-informed care are essential to address psychiatric comorbidities. Medical workshop is needed to assess the progression of hepatitis C, screening of cirrhosis, and address the gastrointestinal dysfunction. Social work involvement is vital to secure the housing and establish consistent follow-up. Conclusion. In summary, in this case highlighted the devastating impact of polysubstance use on physical, psychiatric, and social well-being. It is also reflect the growing body of research supporting the integrated evidence-based practice model. Effective management requires simultaneous attention to medical, psychiatric, and substance-related process. With the right support and engagement, even patients with high levels of clinical complexity can achieve meaningful recovery. Thank you very much. I appreciate it. Thank you.